of introductions, or let's just go straight on?
Straight in.
Straight in. Okay, cool. Okay, hi everybody. Thank you so much for coming, and thank you for your lovely feedback and your kind words. It's really appreciated. Okay, so I'm Dr. Hegde. My teammates, my friends in Hammersmith and Fulham call me Veda. And I work in Shepherd's Bush in a practice called Richford Gate Medical Practice, and I work 1 day a week in the Community Independent Service in Hammersmith and Fulham. So this was a topic Karen, actually, I think there was some clinical need because it's a really relevant topic to what we are doing in the CIS. And it's particularly important because there's a new guideline that's come out this in March 2020. So things have changed. So even as a GP, it's a fabulous guideline because it's really community friendly and we can learn lots from it. And
Good morning, Tanan. How are
Hi.
you? I've just got 2 referrals.
You gotta put people on mute. There we go.
Yes. The only problem is when they want to answer their questions, but okay.
They can unmute. Yeah, wonderful.
Yes.
Sorry for that.
No, not at all. So where was I? Yes, the relevance of this is that it's come out in March 2020, and it's so relevant to us now because we're going to be seeing lots more people in the community who we're going to have suspected VTEs in, especially suspected DVTs, our common bread and butter CIS patient, and we're going to have to make decisions with regards to the current situation, people not wanting to go into hospital. So it's particularly relevant, and we've got some guidelines that are new. So yes, that's the relevance. So let's start with what's the venous anatomy. So first, what is VTE? It's venous thromboembolism. That's what we've heard that word constantly, and I'm going to break it down so you can understand exactly what each of those bits of that word means. It's typically there's 2 aspects to VT. So basically it's a clot in a vein, right? But it could be what we typically think about is a DVT. So that's a deep vein thrombosis, which is, remember, the calf muscle being enlarged. That's the one we see. And the other one is PE. So both of those, the DVT, the deep vein thrombosis, and the pulmonary embolism come under the VTE. All right. So let's go into some of the anatomy. So particularly because DVT is so common, where I'll focus a little more on the DVT side of things. And it's the one that there's a lot of diagnostic uncertainty about, right? So this is the one that we'll focus on, clinical diagnostic uncertainty. Okay. So the anatomy of the lower limbs is that there's superficial veins, and these superficial veins are passive, they're thin-walled, and they're distensible. Okay, so you can see them in that diagram. There's the superficial veins just, below the skin surface, you can see that. And there's the deeper veins, which are thicker, they're less distensible, and they're surrounded by tensely bound tissues, which is the muscle. Now, the reason that this is important, so it's such an interesting, I didn't actually know this until I read it up for this presentation, is that this system, the calf muscle system, is called a peripheral heart, because what it does is that all the blood from the lower limbs, the way it works obviously in the body is the blood. Kevin, I think someone's not muted again. Sorry.
Can I ask everyone to make sure they're on mute, please? I'm muting everyone now, but just make sure when you enter, please put yourself on mute. Thank you.
Sorry, thank you. So superficial veins, so they're draining all the blood from the lower extremities. They're carrying them to the deeper veins through these connections in between. And then the deeper vein, obviously you're working against gravity to pump the blood back to the heart, right? So the deeper veins then, the muscles are acting to contract those deeper veins and to push the blood back to the heart. So the reason, it tells you a little bit about the peripheral heart. There's some wordings here. So basically, the superficial veins goes into the deeper veins, and there's valves, like how the heart has. That's why it's similar. There's valves that stop it from backflowing, to go back, right? So it goes pumping up. Imagine that at one point there can be about 100 to 150 mils of blood in the peripheral heart, and that's how it gets pumped back in. Okay, so the problem when we say there's a DVT, so we're going to go more into that. So that's the system of the anatomy system, right? So superficial veins, deeper veins. And the problem usually is in the deeper vein, right? In a DVT. Okay, so my computer is not behaving at all today. Okay, so venous thrombosis is a condition in which a blood clot is formed in a vein. So that's, remember we talked about venous thromboembolism. So we saw what venous means. Venous means the blood system, which is the veins, superficial and deep. But the venous thrombosis is when a blood clot is formed in a vein. So you can see that. So can you see the valves that normally would open up to allow the blood flow? So when there's a big gush and pump, you're allowing, the muscles are contracting, it's pushing the blood up through this valve, the valve opens up, the blood goes up, and then it closes again, right? Now, if there's a thrombus formed there, and that can be multiple reasons, so we're going to go into that a little bit later. So if you get a clot formation or a thrombus formation in that vein, that's called the venous thrombus, okay? Now, remember that word VTE, so venous thromboembolism. So imagine that big thrombus that's formed in that area. Now, there's a small bit of it gets dislodged because there's circulating blood coming through this area, right? So a small bit of it might get dislodged, and that's called the embolus, which means that it's traveling around the body. And that embolus can obviously get embedded somewhere. And the worry for us is that it get embedded in the lung. And that will cause what we have a PE. Now, let me move on. Okay. So you can imagine again, now what's going to happen when that blood is collected because of that. There's a collection of thrombus, so the blood is kind of not flowing as well as it should do because there's a blockage there. So it's going to cause the symptoms that we see in a DVT, which is swelling and redness of the peripheral extremity, that leg. So below the thrombus is going to be red and swollen, and it's going to be warm, right? So that's classic. We've seen that all the time, and that's the reason, okay, because of the thrombus. Now, this is just for you to know that so smokes commonly in the veins of the leg, the thigh, and the pelvis, and this is known as vein thrombosis, deep vein thrombosis. So just a question, if somebody can unmute, we've already answered this, but why is DVT dangerous? So what reasons can you think of for DVT being dangerous? Anybody?
It may lead to sudden death.
Yes, but why would it lead to sudden death? Because it's only occluding the leg. So what's the big deal?
When it's gonna move, yeah, when it's gonna move.
Yeah, so the embolus is why the problem is, right? So it could lead to sudden death because it might go to lodge in the lung. So we've already got that answer. Okay, so this is what a PE is. That's dislodged. We've talked about that already. So the thrombus dislodged, and that's the embolus, and it's called pulmonary embolus. Pulmonary means lung. Yeah. Okay, so that's great. And there's also something called, so the reason DVT is also like troublesome is because obviously it causes local symptoms, and it also, if you don't treat it fast enough, it might cause a condition called post-thrombotic syndrome, where the person in that leg, the mechanism that those valves and the way that the leg is, it becomes swollen long-term. There might be some sensitivity, there might be pain long-term. So that's why we want to treat these things fast before so that they can heal quickly. Okay, now this really sobered me up. I had no idea this was how serious it was. So untreated PE had this was NHS England data from 2013 to 16. So untreated PE has a mortality rate of 30%. And if you treat it, the mortality rate is reduced to 2%. So that's huge differences for us, right? So, okay. Now, I really like this guy. He's so cute. This man, he's a scientist called Virchow. So in medicine, there's lots of things he's discovered. I was, at the time in lockdown when you're thinking, I haven't done enough with my time. And when you look at all the things this man has done, it's absolutely, it gives you a real complex. So he's all sorts of things. He's very interesting because he was going to train to be in the church, and then he decided to become a doctor instead. And he's discovered lots of things that are really relevant to medicine. So he actually talked about the triad, which decides why somebody might have a clot. So it's called the Virchow's triad after him. And it's pretty simple, right? So there are three things that they're thinking are going to make you more prone to forming a clot. Now you all probably know this in some state or form because you're doing a well score, you're seeing your patients, you're clinically aware of it, and I'm sure that you all are aware of it, but it helps you to put this into perspective. So one of the problems is the blood. So if the blood is hypercoagulating, which means that it's really clotty, so it's more prone to forming clumps and clots and forming a thrombus. Now that could be because of multiple reasons. So in younger people, one of the risk factors is taking a pill. So high estrogen levels, so pill, pregnancy, after a pregnancy, those are the times when you might have a risk factor of a clot. So it's your blood is high estrogen, it's more coagulable. The other things are things that we commonly see in our elderly population is stuff like malignancy. Okay, especially remember, a lot of our elderly population might have had a hip surgery, and remember that's why we always give a blood thinner to them when they come out after a hip surgery, is because of this, because you know there are multiple reasons, but this is also one of them. So immobility can make it more this. Obesity, things like that can all add to it. Sepsis, they make them more, that's why remember they go into hospital and they always undergo that VTE pathway, and they're always given prophylaxis because they might go in with sepsis or any of these conditions and they will need to have that blood thinner. So it's a the blood, that's the problem with the blood. The other problem is a problem with the vascular wall. So the wall of the vessel itself, there is a problem with. So you could have issues where you've had a cut. For instance, all of you might have seen cases when you've had thrombophlebitis, when they've put a catheter, cannula in, or they've had a central line in because of they've been in ITU. So things that have caused damage to the blood vessel could also cause it. Okay, like a catheterization procedure, post-heart surgeries, things like that. And the other problem is circulatory stasis. So this could be heart failure, this could be, I'm just going to read that and see what else is there. Pregnancy, immobility, and you know that as well, right? People with a long flight, people who've had overweight, they're very bedbound, their mobility has changed suddenly in the last few weeks. That's one of our risk factors. So this is the Virchow's triad. Okay. So this is a nice guideline. I'm going to put the link is there in the presentation. So when you guys want to read if you want to read the thing yourself, the guideline yourself, you can. So this is the guideline that's come out in March 2020. Okay. So our first case. So get ready to unmute your buttons now. Okay. So he's an 8-year-old male. He's had a recent holiday to visit his son in America. And now his GP has referred us, he's called his GP, and his GP has referred him to us with pain and swelling in his right calf. Has been seeing this patient. Okay. So now I kind of want to answer. So what are we going to do for this poor gentleman?
You need to assess him.
Well, you're gonna look and you're gonna feel.
Sorry?
You would look and then feel.
Correct. Okay, perfect. So look and feel. How soon? You said assess him. How soon do we need to assess him? That's important for us now.
As soon
As soon as possible.
As soon as possible. So we're prioritizing him quite high, right? So
Yeah.
we have a CIS 2-hour response, and so we have to see him within that 2 hours. But as soon as possible, even earlier if possible, we want to see him. And I'll tell you why in a little bit. You're going to realize why. Okay, so you're going to see him as soon as possible. Yeah, assess him, look, feel, excellent. What else?
And by his appearance, we can see that he's dehydrated. He might have a long travel and holidays and not drinking enough. So,
excellent. That's also a risk factor. Brilliant.
I mean, you will start your assessment with the right calf pain. You do your well score. To try and come up whether the person is at risk of DVT or not because of the traveling.
Excellent. So well score you're going to do, which is brilliant. And of course, you're going to do all your things that you always do. So you're going to do a head-to assessment. You're looking at his history to see the risk factors because you're going to need that for the well score, right? So that's brilliant. So you thought about the well score. Okay.
And we can have a look at the past medical history as well. We don't know whether the patient is got hypertension, AF, or other underlying problems, vascular problems that can exacerbate this further.
Perfect. So you're going to look at all the things, the way you're going to do your history, you're going to see the presenting complaints, how long he's had it for, you know, what the symptoms are like, has, like you said, past history, what medications he's already on, and you're going to examine him, look, assess, feel, all of that. Perfect. Look, feel, touch, isn't it? Okay, so I'm not going to teach you all of those examination bits because I know you guys know it already. I just want to highlight one important thing. So you talk about well score. Let's go into each of the well score points when we're doing this now, okay? So active cancer treatment, so that's going to use, so you're looking at how you're going to, remember the Virchow's triad? Again, you're looking and you can see that there's hints of that here, right? So paralysis or paresis or recent plaster mobilization of the lower extremity. So somebody who's immobile, okay? So their calf muscles, again, think of the mechanism. Their calf muscles, something's making them immobile. So their calf muscles are not working as hard to pump the blood back, which means that it's just sitting there stagnant, and that's causing the clot, right? So the recent immobilization, some new changes. Recently bedridden, major surgery. So all of this is part of history. You're going to ask that. So recently immobile, this man has been on a flight. Now, I always, this is so common. I've seen it at least 3 or 4 times in general practice when there's somebody who's come back from a flight, and I don't know how common it really is percentage wise, but I have seen it in my practice. So it's very important to remember that he's flown to America and come back. Okay, so localized tenderness over the distribution of the deep venous system. So you guys remember that photograph that we saw of that thing? Oh, that's it. So the deep venous system is all along the back, right? You can see that when you look at that. So it's important. That's why we remember we do that test when we squeeze the calf muscles. And this is the reason, because we're assessing the tenderness over that area. And it's part of our well score as well. Okay, so, and then one of the scores is entire leg is swollen. And then this is an interesting, so calf swelling at least 3 centimeters larger than the asymptomatic side. So I'm going to come back to that in a second after we read these, okay? So the size of the calf is important as well. And then collateral superficial veins, so varicose veins. Again, remember varicose veins are going to make it stagnant the blood, so that's another reason. And previously documented DVT, okay? So you're creating the score system and you're doing it. Now, the important thing I wanted you to talk about here is how do we measure the calf in, how do we measure the calf in this man? Oh, I clearly missed my slides somewhere. I'm going to go look for it later, but do you know how we do it? Given the answer to it.
How do you measure the calf?
So this is important because all of you as nurses, I know that you guys probably do calf measurements for...
So from the measuring tape, yes. And well, depends on where you query where the DVT is.
So it's a calf DVT. So it's the calf is swollen, this man's.
So the circumference of the shin, where in the affected limb, and I will do the other side as well to compare both sides.
Correct. But there's one really important, so the standardized method. So, you know, I used to always measure obviously the same distance from the top to, you know, you can't do it randomly, right? You need to make sure that you're doing it the same distance on both sides because it's a comparison with the other side. So it's 3 centimeters more than the other side. So that's very important. So this is what the guideline says. The BMJ best practice guideline. This is what it says. It's 10 centimeters below the tibial tuberosity for a calf DVT, for a lower part DVT. And for a thigh DVT, so the upper part DVT, it's 10 to 15 centimeters above the upper edge of the patella. So it's really important because when I document my calf measurements for the hospital, I always offer medical legal purposes. For instance, suppose, you know, we want to prove it's not a DVT, then what I always do is I always mention 10 centimeters. I'd write it down saying 10 centimeters below tibial tuberosity. That is how much and this is the circumference at that point. Now, in our old, this is what the tibial tuberosity looks like. Okay, this is in a person with, it's very prominent in this one. But in lots of our old patients who might be overweight or have pedal edema already, or it's very swollen, we can't feel the tibial tuberosity, right? And that's totally okay. There are times when I haven't been able to feel it. So what I just do then is I just make them sit in a way as straight as possible, and I do it from the upper patella lip, like how they said, you know, upper edge of the patella, and then I go down 13 centimeters or whatever. So at least if you're able to compare, I don't know if it's a right or wrong thing to do, but I think if you're able to compare them at the same place, and you can do multiple measurements as well, right? Just to see what it is. So as long as you're able to compare and it's 3 centimeters more than the other side, that's very important. So don't forget to write which point you measured the calf at. So that's just important for your well score. Yeah. Sorry to have to push you around like that. Okay. Okay. So now this man, so you've said you need to do the well score. Excellent decision. So you've done all that. Now he is coming up. So how is his score now? Can somebody do his score for me? Oh, you don't know any of the history, but his calf is swollen 3 centimeters more, and he also has had this immobilization recently. So he's definitely he's not had any previous DVTs, and he is tender along his deep venous system. So he's got 3 points there, right? So if you can see, 2 or more is high risk of DVT by the well score. Okay, so now what are we going to do? So we've got a well score, 2 or more is high risk of DVT. So what's our next step?
To organize scan.
Excellent, yeah. So to organize a scan. So how are you going to do that?
We can organize by GP ambulatory scan. So
yeah.
the patient has to go through A&E.
Yeah.
It will be quicker. Yeah, so
excellent, perfect. So
in ambulatory, they do bloods and they, yeah.
Yeah, exactly. So this is a great question, and in this person, I don't want to leave it to you. I mean, I can put it up. If you were sitting in front of me, I would make you raise your hands and tell me how many of you would do a D-dimer first. But so the guideline, the NICE guideline that's recently come out is saying with somebody 2 points or more, you don't need to do a D-dimer first, because it's not going to make it. There's such a high risk, such a high suspicion that you need to get a scan anyway. So, and the scan, the important thing, so that is why time is so important in this man, because a scan it should be done within 4 hours. This guideline states, okay? So you need to see him quickly, and once you've decided well score 2 or more, you're saying, okay, this man needs to, you know, you can't, by the time you get a D-dimer, he should have been in the scan department anyway. So send this man on to see, to go to the A&E, and they can do all the bloods in one prick there, and they can also do the scan. So he fulfills that pathway. So you're right. So within 4 hours, so this is really important, guys. He needs to go to A&E he needs to have a scan within 4 hours. So you're sending him up quickly, and ideally calling ambulatory care and telling them that we're sending this man up with suspected DVT, right? Okay, great. This is a screenshot. It's a fabulous flowchart. It's a screenshot that NICE and BNF have made of how to manage a DVT. So you can see well score more than 2, DVT likely. So you immediately send them to this scan within 4 hours. And then, anyway, so the second part, don't look at it. I'm going to go into details of that in the next case, okay? Now, we'll cover all of this. So this is just there for you to look at later, okay? Okay, so is that all clear? Any questions from this case? Don't worry if you have questions. We might answer them in our next few cases. I'm kind of breaking up the information for you, so you might get more information in the next few cases, okay? So nobody said anything, so I'm going to move on, okay? Okay, so our case 2 is a 90-year-old woman. She's got mild chronic cardiac.
Veda, apologies. If anyone has questions in the meantime, you can write them into the chat, and I will try to answer them.
Oh yeah, perfect. Thank you, Karen. Okay, so this lady, mild CCF, she's got chronic pedal edema, okay, common patient, we see her all the time. And her right calf is now warm to touch and slightly swollen, right? And so the CIS referral comes at 6 p.m., just our last referral of the day. The GP calls us and says, please, could you see her as your last patient? Because we need this woman seen. So frail old lady sitting at home. Okay, so now with her, what are our next steps? So you've already covered some of the steps. I won't make you go through them again. So you're going to take a history, you're going to look and feel and assess. Okay, and you're going to measure her calf. So when you think of the well score, your I did this presentation last night, very last minute. So I don't know my presentation myself, some of it. So you have to bear with me. So you've done the well score, and her well score is 1 because she has a very mildly swollen, like it is definitely more swollen on the right side compared to the left. And it's a new swelling, so it's acute. It's happened in the last 2 days, but it's only 1.5 centimeters more, and it's hot and warm and red. Okay, so she does have a unilateral bigger swelling on the right-hand side, but it's not more than 3 centimeters. And let's look at our well score again. She, nothing has changed. She is bound to her chair quite a lot. She's got very poor mobility already, but it's not a new change in her mobility. So that's important. This mobility has been static now for a few years. And there are, she's not particularly tender. She's got a little bit of tenderness, but not too tender. But these are very subjective, right? Some patients are more tender, some patients are less tender. You can't 100% rely on. It's just a score, remember. So that's again, keep that in mind when we're doing our assessments. So her score anyway is 1 point. And she's only got it because she's got slight asymmetry and because she's a little bit tender on that thing. So how are we going to manage her? Remember, there was parts of the presentation I was trying to hide from you. The flow chart, I was telling you that in some cases you might not need to do that, or you might not be able to do that.
The same management as the other patients, like history taking and initial assessment.
Correct, yeah.
Medication and all these. And also examining the affected limb. For the well score is there already.
Correct, it's 1.
We'll see a full set of bloods for her.
Correct.
Yeah, with the D-dimer as well.
Yeah, brilliant. So D-dimer, full set of bloods. What are the full set of bloods that you're going to do?
So FBC with a CRP, and although there is no signs, but there might be an underlying inflammation going on somewhere.
Inflammation going on somewhere, exactly. Okay, perfect.
So, because there is pain, but it is less pain. It is tender, but don't know. And also we are going to measure the limb. Yeah.
Remember, I don't know why it's not there in this DVT score, but remember there was 1 point. Earlier there used to be a minus point if somebody had, they had another diagnosis likely. So with this lady, she's not particularly tender when she's just sitting. And she's feeling that this calf's a little tender. There's a bit of a nick in that area where, she's hurt herself. She had a skin tear there a few days ago. So she could very well have a cellulitis instead of a DVT, right? So there is an other possible probable diagnosis in this patient's case. Now the important thing is the management, right? So you said so you examined her perfectly well. So her well score is 1. How would you manage this patient differently to the other patients? So the other patient's well score was 2 and more. And that patient was referred to you in the morning. So there was a big difference. You could send him to A&E, the ambulatory unit. This patient's been referred to you at 6 in the evening. So by the time you finish reviewing her, it's become 7:30. And now what? Now what are we going to do? You said blood tests, which is perfect. So the D-dimer you've done. Right.
CRP, full set, CRP, MPC and CRP, and also the risk function.
Correct. Excellent. So liver functions, Usenes.
But also important to know her observations is she got a raised temperature or not? Is she shown any signs of sepsis?
Yeah.
Yes. So as per initial assessment, you do your observation and head-to-toe assessment, and you feed back overall picture to a GP.
Correct.
Well. So if we're suspecting it's rather cellulitis rather than DVT, a person would need to start antibiotics ASAP.
Correct.
So yeah.
Also with
you're right. So but there's still, but you can't 100, you're anxious because this leg, there's asymmetry in this leg, right? You're not 100% certain. It's not, she's immobile. There's like, it's not as mobile as she normally, I mean, compared to other patients. She is tender, it's hot and red. It could be, we don't know for sure, it's not a DVT. So you're right that you're starting antibiotics for her. So the guideline says that with this lady, you also do check with her D-dimer. So you wait for her to come back within 4 hours. You want to see the D-dimer again within 4 hours. It might not be possible at this stage. Or you start her on anticoagulation just for this night until we can organize her to have a scan or a negative D-dimer. So you can start her on, I mean, obviously you guys might not be able to do that straight away, but the GP can start her on anticoagulation that night, just in the community while we're waiting, because we don't want this lady to go to hospital and wait around when she's well in herself otherwise. So we're protecting her from the DVT side of things as well. And we're saying that the most likely diagnosis is cellulitis, but we're not going to rule out the fact that there's also maybe a DVT. So we want to make sure that we start her on something until we've ruled it out in a confident way. So until the D-dimer result comes back and it's negative, or until the ultrasound scan is done. So all of this is there.
Veda,
yeah.
Can I quickly interrupt and ask a question
of course,
here?
Yeah.
So if we're saying it's 7:30 at night, and we assess that the regular practically for our team, the regular GP won't be here anymore, and also do we need to stay up until midnight to check the D-dimer?
No. So obviously here it's going to be you can make a clinical decision with the out of hours GP on call. If this patient has no contraindications to taking an anticoagulant, one dose of the Rivarox, one of our I'm going to talk to you about the anticoagulants in a minute. So one dose of that overnight is not going to be a problem. As long as there's no other contraindications, she doesn't have a massive bleeding ulcer or something else, then it becomes really complicated. And you might need lots more help or hospital help then. But if it's not a very complicated case and you're covering her for a couple of days until you have the results, with some anticoagulation, it's not a bad thing. And the out of our GPs, with this guideline, you can easily, they'll know about it. They'll be able to help you.
So for our team, practically the best way forward is if we found this at 7:30 p.m. and had this assessment, a well score and the nice garden in our head, I looked it up, a phone call to the out of hours GP and a sort of discussion with some senior medical input from the out of hours GP and guidance there. Documentation would be the right thing.
Exactly, perfect. And the documentation that, you're obviously sharing some of these risks with the patient as well, which is what we are taught all the time as community practitioners, that we have to explain to the patient that we are weighing things up and saying to them, we don't want to put you through an overnight hospital admission while you're waiting to have especially because it's not going to be available overnight to do an ultrasound scan. So you're kind of weighing things up for this patient and saying, this obviously hospital might be the safest place in some case, but in your case, they're not going to add a lot more. So let's start the treatments. Let's get the senior medical input. And then tomorrow when things open up, then you can organize, if the D-dimer is positive, then you can organize a scan. Now, sometimes obviously D-dimers can be falsely raised, particularly in things like infections, in older age, in renal problems, you can have a raised D-dimer. So that might confuse the pictures. You will see people with false positive D-dimers. A negative D-dimer is very reassuring, but you can see people with false positive D-dimers commonly. in our practice. So that's when you might need a scan anyway. So it can all be done tomorrow when you've already started them on the medications. Is that okay? Okay, cool. I'm not hearing anything, so I'm assuming that
sorry, can I say something? You know,
of course.
When it's 6 p.m. like that and you call out of hours, the reality is that if you query DVT, they will tell you to call ambulance. Unless if the patient's GP is still in practice, then they are willing to go by your route that you're suggesting. But if you say query DVT and you tell them the well score, their past medical history, they will just say call the ambulance. They won't come out.
You're right. I agree with you. That does happen. I agree. It's because we're all scared sometimes and and when we haven't seen the patient ourselves, it's a bit harder sometimes. So I don't. It is a difficult situation to be in, isn't it, Karen? Like you can't. It might happen, but there will be some GPs if you get managed. Usually, GPs should have given you their mobile number when they made such a late referral. So they might have, or they might have already planned ahead and given you the prescription for both the antibiotics as well as the rivaroxaban or the anticoagulant. Sometimes they might have already done that for you. So it might be something then to think about when GPs refer a patient like this, to prompt them and say, is it possible for you to leave a prescription? So in case it does turn out to be this, can we also do that? And then we can speak to the out of hours, get confirmation. I don't want to make you guys do too much alone. It's really important that you have medical support when you're doing it, but these are just thoughts. I don't know, Karen, how do you feel about that?
Pardon?
Yeah. I said these are just thoughts. I'm not.
Okay.
Don't feel that you're put on a spot at all. Like these are just things that you could try and tackle it in this way. It's just to save a hospital admission if we can. But you've got to work with what you have in that moment. So there's never any blame or pressure. So don't worry about it. Okay. So treatment in the community. Did I answer your question? I'm sorry if I didn't.
Yes, you did.
Yeah. But I can only apologize that it does happen to all of us. Okay, so treatment in the community. So blood tests you guys have already done. Okay, and then the first line and this is where the guideline has changed in a very big way, that they're really encouraging in the community for us to treat people with something called dual oral anticoagulants. Or they're called novel, NOACs or DOACs, so novel oral anticoagulants. And these are fabulous because remember the old-fashioned stuff we talked about always was warfarin. We did all that INR testing like you asked me about it right now. So this is the new stuff, the rivaroxaban, the apixaban, the endoxaban. This is the new stuff that's come out. They don't start warfarin as first line anymore in the community. And that's the big change in this guideline. I have a chart later with a summary of all the treatment options that are there based on the patient, just for your knowledge. So we'll go through that later and you can look at that later in your own time. Okay, I'm just going to look at time because I'm so naughty. I always run over. Okay, so this is apixaban for acute DVT or PE. This is the doses that are there. This is on the guideline, or rivaroxaban. Both of them you're familiar with. What was interesting is that the rivaroxaban, it should be taken with food. So if you guys ever come across a patient who isn't taking them with food, just remind them because it changes the absorption drastically in a very big way. So maybe people who, they wouldn't know it all the time. So make sure that they're taking it with their meal. Okay, so these are two DOACs that are commonly used. There's a lot of, in that NICE guideline, there's a whole lot of reasons why they've chosen these two. And it's to do over the other medications that we previously used because the bleeding risk is lower. And obviously, if you think about it practically, the cost is lower in the wider term because with warfarin, there's so much of, like checking what's happening, looking at everything keeps changing constantly, right? Even with this, it obviously can change, but it's a little safer, they say, the latest guidelines.
Can I ask? If that lady already on a apixaban treatment due to her AF,
she didn't have AF.
Oh, she didn't have AF.
No, but just in case, like, we will be patient and you'll see in.
Oh yeah,
already
great
on
question.
Already on a treatment of apixaban. Are we going to make any difference or just leave things the way they are?
So the question with that is, this is so reassuring to us as clinicians. She's already low risk. And we know that she's anticoagulated to some extent as well. So it's reassuring. So the apixaban dose is a little bit higher when you're giving it for a treatment of a PE and VTE. So you'll have to, the doctor will make up the difference, and they'll give them the treatment dose for this until we know for sure that it's not a VTE.
Another question, does this DOAC rely on the weight of the patient? What about those patients who are underweight and with these symptoms?
There are guidelines about that because of the absorption and the dosage and things like that. So if it's less than 50 kilos, there are some changes. I don't know exactly the DVT or PE dose, but when AF, we above 80 years old, and if they are less than 50 kilos, we half the dose. So we make it 2.5 twice a day. And also we change the doses based on certain other conditions. I'm going to go into that a little later. One important condition for us that we change the dose for, we'll talk about it a little later. So there's no point, I've given the answer away, but we're going to cover it. Okay, so yeah, that's a really good question. So that could happen that she's already on anticoagulation and you just make up until you confirm that this is definitely not a VT in this case. Yeah, great question. Okay, so this is the overview of the medications. There's obviously lots of little bits to it, like if they actively got cancer, there's a change in the treatment. If they have a condition where their blood is very clotty because of a medical condition, a hereditary condition, like an autoimmune one called antiphospholipid syndrome, then again it changes your management. If it's a recurrent clot, so they already had a clot before, they stopped their treatment as per advice, and now they've got another clot, then again it changes management. So this is just giving you an overview, but in our acute setting, it doesn't matter to us to such a big deal in a CIS setting. Okay. Now, quickly, just briefly going over what acute PE is. You guys already probably know about it. Again, this slide is just for your information, so you can look through it. With somebody who has PE symptoms, you will likely go to send them to hospital, even if it's in the middle. Like that same lady, if she had symptoms of PE as well, you might be less likely to keep her at home. If she's got shortness of breath that's new, if she's got this chest pain, you're not going to keep this lady at home. So if she's got any of these symptoms, even if it's 6 in the evening, this woman is going to go into hospital. So this is just for you to know. I think anybody with a PE, even if it's daytime, we're going to send them to A&E quickly, right? So this is just, again, for you to know what the percentages of how common they are. Okay, this is the pathway for PE. Again, just for knowledge, just for you to have when you look at the presentation again, if anybody is more interested in that. Okay, so our last case today. Okay, so she is a 70-year-old female. She's had breast cancer. There's so many giveaways in the slide, but it's not really a great quiz, but I'm trying. So 70-year-old female, breast cancer, she's having radiotherapy for that. She's diabetic nephropathy on dialysis. And so remember last time we learned dialysis usually means EGFR less than 15. So the kidneys are going to be pretty rotten at the moment. And she's got a right upper limb swelling, and it's red and it's hot, and it's come on suddenly in the last day. Okay. So what, really should know my slides better, Karen. So what does this lady have? She's got a few risk factors, remember, guys?
Yeah. The well score already will be high.
Yes.
So she's a very
well score
high
is
risk.
definitely.
Yeah, so she needs urgent scanning.
Yeah.
ASAP.
I put this here just because I don't want you to forget that we always think DVTs are synonymous with calf DVTs in our heads, right? But obviously deep vein thrombosis could be anywhere. So I just want you to remember that you can also have them in the upper limb. So in upper limb swelling, when you're seeing a patient, it might not be just, because this lady with radiotherapy, breast cancer, she could just be having a swelling because of the radiotherapy, localized swelling and tissue reaction and lymphedema and things like that. But we're worried about we can't write it off and not do a scan in this lady. So she's going to go into hospital urgently and get that scan. So Just a little bit to tell you about upper limb, upper extremity DVTs. So 11 to 14% of all DVTs are that. The risks are, particularly these are the risks, are cancer, smoking, cardiac procedures like pacemaker, post-ITU stays. We've had central lines in, so this caused some damage to the vessels around there, so that could cause it. Okay. Now, we know now that our guidelines are saying that our first line of treatment is going to be a DOAC, NOAC, which are these apixaban, rivaroxaban, those agents, which are nice, easy to monitor. They monitor them annually. They have less bleeding risk. They're much easier to take for patients. There's no dosing change constantly. So this is what we've learned. But with renal impairment, this patient with EGFR that's low, do you know if it changes any management? Don't know if you've seen any patients. The answer is yes. I feel like I'm so obvious, but yes, so the answer is yes. And, you know, so the options are stuff that we used to use before frequently, right? We used to use low molecular weight heparin. So we used to give the injections, remember heparin injections? God, I can't plexane injections that we used to give in the community and in the hospital. And you're giving with the oral anticoagulant like the vitamin K antagonists, which is the warfarin and the coumarin. So those are the medications. And so remember, we did 5 days until the warfarin dose, like until the INR got to a stage that it was stable and safe. We gave them the injections as well as the warfarin, and then we can stop the injections. Just like our old, you know, how we've done it for many, many years. This is exactly the same. So with renal impairment, remember, it's important. And that is why with NOACs and DOACs, every year we have to annually check the kidney tests very importantly, because in case they start going to a level that's not safe. So below 30, EGFR below 30, we have to start reviewing it and maybe having to switch it. So that's a little bit guideline based. So the specialist sometimes says, don't worry about it, but then we have to start looking at it. Okay. So that's important for you to remember, renal impairment. Okay. Now this is a last slide. Karen, I'm so excited. I'm actually on time today. So this is something, I think this was interesting. Karen sent me this, this presentation, this bit of the thing. And so apparently COVID-19 is now associated with, because it's inflammation and, you know, disseminated intravascular coagulation, which is a hypercoagulable state basically, and immobility. So it's apparently higher risk, they're saying now. It's too early maybe. So especially with severe disease, it's causing some complications in the lung because of the scarring in the lung from the pneumonias and things like that. So again, it's important for us to think about. And I think it's important for us to be aware of this guideline particularly, that now on discharge after COVID-19 infection, a severe infection, and if you've been in hospital, any of our local Hammersmith and Fulham hospitals, you might actually need to start them on a prophylaxis. So they're continuing their prophylaxis, their anticoagulation, even in the community. So this is what they are doing. This is just for you to know in case you wonder why a patient started on this after they've come out after an admission. So these are their guidelines now. But yes, it's done. Yay. Any questions? I don't know if I've covered everything you wanted to know. Now we've got 5 minutes more for questions as well. I can summarize for you then. So in summary, our important points are: patient during daytime, refer to us. We're going to go about as quickly as possible. We're going to do a well score, and that's going to help us decide our management. We know how to do our well score. We've already talked about it. We're going to, if it's high, if the well score is 2 or more, we're going to send them urgently in to ambulatory care, A&E, get them that ultrasound scan. If it is low, then we have the option of deciding, maybe doing a D-dimer first, and especially in the daytime, we can send it as an urgent, maybe to the hospital and say, please, can you call us with the result, or, you know, let us know as soon, we want this urgently, so mark them as urgent bloods, and so you'll get the result in a few hours, and you can then act in this.
Sorry, Veda, the D-dimer should be done as per guidance within 4 hours.
Oh, the guidance, yeah, exactly.
Yeah.
So, in the hospital as well, they would mark it as they would do it. Oh yeah, exactly. Yeah, they've got their systems in place. So yeah, so it will be done then. So just see, you could, and then you get your D-dimer, and then based on that, there's the flow chart is very easy to understand. So then you decide if you want to get them a scan if it's positive, or if it's negative, then think of the alternative causes of why their leg is swollen. That's a whole different topic, another day. Talk about causes of leg swelling, but yes. So then I think you guys know most of them. And then the treatment. So that's really interesting that you learn. So I think two great things that came out of it was that you could plan ahead and think, if it's cellulitis, start the antibiotics, and there's no contraindications, no risks of bleeding. Then we could also ask the GP to consider starting the anticoagulant while we're waiting for the D-dimer results. If it's overnight, it's difficult. And the other important thing was, what if they're already on anticoagulation and we are worried that it could still be a clot? Then what? So then you can maybe up the dose to the right level and wait for daylight. Is that okay, Karen? Is there anything else that you want to add to it?
No, I think, thank you very much. I think these examples and these patients, that the cases you gave is really, really good. I think what we obviously may see is that some of the patients are not black or white, and then some of them have elderly, frail, have lots of multiple problems.
Yeah.
And then we may not know exactly what's going on. So I think, in doubt, if we do a good assessment, a clinical assessment, measure the calf diameter, think about the risk factors and the Wells score, I would definitely then discuss this with the patient's GP, or worst case scenario, out of hours GP, and ask them for a sort of senior clinical decision on it. And again, we are likely to see these cases potentially a bit more now, or I've already seen it a bit more, because our patients do not want to go to hospital. The hospitals aren't overflowing with patients at the moment. They're very worried about COVID, and we may come across this a bit more frequently, because patients will refuse to go to hospital. And I think if we have a high suspicion of a DVT, the Wells score is high, then I think we need to advise these patients to say, we're really worried that you have a blood clot. That blood clot can go into your lungs, up into your heart, can cause you a stroke or heart attack. Appreciate that you don't want to go, but these are the risks. Make sure the patient
that's
has the capacity and document that.
Yeah. So I think that's a big, another thing that could have been added to the slides. I'm so sorry I didn't do that, because that's very relevant, isn't it? People refusing to go in, and then you're having to do a D-dimer on a high-risk patient at home, even though they should be having an ultrasound anyway. So this is not normal times anymore. So I guess things might, every case, like you said, they're not black and white anymore. It's all very colorful. So,
yes. Yeah, unfortunately. So that's what we are facing, especially in the sort of puppet teams, isn't it?
Yeah.
Where then patients will call their GP, call LAS, but then refuse to go to hospital because they're worried of COVID. Or getting COVID in the hospital. And I think also it's important to tell the patients that the hospitals are segregated into hot zones and cold zones. So we have red areas, we've got green areas in the hospital. So I think if we think a patient should go to hospital, to reassure them, just as a bit of side point to the whole DVT teaching, but I just thought I'd mention it. I tell the patients to say, appreciate you're worried, but there are green zones. If you have a leg swelling or we're worried about the blood clot, you will go into a green zone. As infection control, everyone is abiding to it, and you are unlikely to come in contact with someone who has COVID.
Exactly. And the risks might outweigh, the risk of contracting COVID might outweigh the fact that you've got this big lung clot, isn't it? So if it develops into a lung clot, which is crazy, 30% mortality in untreated P. That's crazy, isn't it?
Yes, absolutely. It is. Okay, well, it's 11 o'clock, Veda.
Yay! I feel so accomplished today. We're finishing on time.
we're finishing on time. Just got a few. Thank you. I've got thank yous. Thank you for listening. We're obviously recording it. I'm going to actually stop the recording now, and